Okay, and good afternoon, and welcome to the Davies Use Case webinar being presented by Ochsner Health System on digital medicine. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes the outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award's winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information technology and enabled care delivery. So it's my pleasure to welcome our speaker for today, Dr. Todd Burstein from Ochsner Health, and I will turn the presentation over to you, Dr. Burstein. Let me...
Fantastic. I'm still waiting to... here we go. Perfect. Thank you, Arnold. Appreciate that introduction, and I'm happy to be here today to present this webinar. I'd like to give a few thanks right off the bat to folks who've made this work possible. First and foremost, Dr. Richard Milani, who's our Chief of Clinical Transformation, has been crucial in setting up all of our digital medicine projects. Amy Quirk, who's the CEO of our Innovation Ochsner program, Jonathan Wilt, as well as Kevin Driscoll, who've been very helpful in the creation and design of this program. We have another case presentation for this Davies Award on population health that centers on the change in the payment models from fee-for-service to value. And one of the things that becomes very clear as you're in a value-based market is this need to achieve the triple aim of being able to improve quality, reduce cost, and improve patient satisfaction. And when that came to the care of chronic conditions and common conditions, we felt that one of the most valuable tools in being able to achieve that triple aim is the use of digital medicine. And so we have three digital medicine projects that we've created here today at Ochsner, and we'd like to walk you through those and talk a little bit about how they were done and what the outcomes and success was from each of these programs. So we're going to talk a little bit about the governance, the three programs which are centered around hypertension, around routine obstetrical care, and around diabetes, and then specifically talk about the outcomes. When it comes to high blood pressure, we know a little bit about the role of ambulatory blood pressure measurement in the outcomes of the care of hypertensive patients. First, we know that it's actually more accurate to know what the blood pressure is doing at home than what it is doing here in the office. And in fact, it took several more readings in the office to actually achieve accurate correlation with what the blood pressure was doing at home. We also know that if we monitor what the patient's blood pressure is doing at home and adjust therapy based upon those results, we're much more likely to get control. So the Hyperlink study showed a 71% control rate versus 53% when we only look at the blood pressure readings in the office. And we know that that actually translates to improved outcomes because the Hyperlink study and two other trials showed a reduced coronary heart disease events as well as reduced stroke events in patients who had their blood pressures monitored and adjusted based upon what their home readings are doing. When it comes to obstetrical care, we know that mothers are busy and that there are a lot of office visits required during a pregnancy, and so we want to try and achieve the best patient satisfaction and consumerism results with these patients. We also know that while complications are uncommon during pregnancy, they do occur, and when they do occur, they are significant, including conditions such as preeclampsia, as well as even just significant weight gain that can occur with pregnancy that can cause all kinds of issues with both gestational diabetes as well as diabetes after the pregnancy, and all other kinds of health concerns related to weight gain. So it was really important for us to try and see if we can address routine obstetrical care in a way that outreaches to the patients. And we also felt that there was an opportunity for our patients to connect with pediatricians. This was a gap in the process of the connection between obstetrics and pediatrics that we felt we had an opportunity to intervene on. And finally, when it comes to diabetes, is probably the clearest evidence where this type of increased outreach has tremendous benefits. We've known now for about 20 years that reducing A1C levels reduces complication rates. Both microvascular and macrovascular complication rates are tied to glucose control. And in fact, each A1C above 8% has been shown to double the risk of having a cardiac event. We also know from the Geisinger data that was recently reported that in their study, each 1% drop in A1C reduced the healthcare costs that they saw by over $8,000 per patient per year. So it has significant financial implications. But we also know that the tighter we control diabetes, the higher the risk for hypoglycemia. So this isn't just a matter of dialing up the medications. You actually have to be very careful and monitor patients closely for hypoglycemia. In fact, the studies show that if you drop the A1C from 7.5 to 6.5%, there was a 400% increase in the incidence of hypoglycemic events. We also know that the time window for A1C is about 3 months, and so being able to track and see how these sugars are doing on a daily basis has an increased ability to move the needle on a more rapid way. And apps have been shown to actually do this. So we've seen apps that have been out in the literature that showed an average drop in A1C of 0.5% or so without increasing hypoglycemic events. So all of this kind of led us to the belief that reaching out to patients and through digital medicine to help control their diabetes was an opportunity for us to succeed on both improving quality as well as reducing costs. As far as the governance structure, Ochsner spun off the Innovation Ochsner team a few years ago, and we did this as a way to try and push and accelerate innovation across the system, but yet being able to tie it back to the routine health care of our patients so that we can expose our patients to the best and brightest solutions that we could develop. The digital medicine care team sits in the Innovation Ochsner group directly under administration, and it's tied with our technology and analytics team, which are used to help drive and create some of these programs. We just received some very nice press, actually, from the Washington Post on our digital hypertension program. This came out in July, and we're very excited to see that the work we're being done here is being honored and recognized nationwide. So why is high blood pressure a problem, and especially a problem in the Gulf South? Well, I think, again, this picture shows 1,000 words. Really, we're at the epicenter of the hypertension epidemic and difficulty with complications from hypertension in this Gulf South area, and Louisiana is at the center of that. So this is a very large and important problem for us. Let's talk a little bit about what we did with the digital hypertension program. Specifically, we're going to outline the eligibility, how we captured the data, some information specifically about the device integration and design, how we developed a guideline-based care program, and then after we finished doing the pilot, how we operationally deployed it, and what some of the outcomes have been from the project. The project began with a pilot where we looked at folks who had blood pressures that were uncontrolled, over 140/90, at least 3 visits in the last 18 months. Since the pilot has concluded, we've now opened this up to anybody with a diagnosis of hypertension can be eligible for referral into the digital hypertension program. We required patients to have a smartphone, either Android or iOS platforms. They had to be able to purchase a wireless digital blood pressure device, although the cost of those devices has come down significantly, and they're now under $30 to $35. And we did require, as we were going to communicate actively with our patients, that they had to be active on our MyChart patient portal called Ochsner. We realized that we needed to capture a lot of information about these patients, more than just what was recorded already in their electronic health record. And so we developed several questionnaires to ask information that we thought would be relevant to the care of their hypertension, and then sent those questionnaires out through MyChart. So we developed information and recorded information about patients' diet, specifically their sodium intake, their alcohol consumption, incidence of depression and depression symptoms, their self-reported adherence to their medications. We developed a questionnaire for looking at patient activation, or how engaged they were in their health care, as well as their physical activity, their health literacy, whether or not they had financial insecurity, and then some screening questions, including the stop-bang questionnaire for obstructive sleep apnea. We also looked at specific labs and other vital sign data such as BMI and our electronic health record to try and compile a complete picture of our patients that we were taking care of in the digital hypertension program. We allowed our patients to use one of two different Bluetooth-enabled blood pressure units, Y-Things and iHealth. Those units send information to an app on their phone, and that app is integrated through Apple Health Kit to integrate the data directly back into Epic. At Ochsner, we created, as part of our Innovation Ochsner team, what we call the O-Bar. The O-Bar is present at several of our sites and allows technical staff who are experienced at phone apps and that we have specifically designated as being valid apps that we'd like to have on our patients' phones, to have the patients come to the O-Bar. These technical assistants are able to install the apps on their phone and show them how to use them, including how to use these devices. So they sell these Bluetooth-enabled blood pressure monitors at the O-Bar, and then they can hook them up to the phone and install the app and get everything set up for them. We asked our patients to have one recording of their blood pressure per week, but encouraged up to 3 to 5 blood pressure readings per week. And if we did not get a recording within 8 days, the patients received an automated text warning alerting them that they needed to send in their blood pressure readings. We assembled a team of folks to begin help care for these digital hypertension patients. So these included PharmDs who were able to adjust the medication regimens for these patients based on guideline-based therapy that had been approved by our physicians. We also hired health coaches to help with lifestyle and adherence factors, as well as improve patient education and activation. We created hypertension education material and put it on a specific dedicated website and gave our patients access to that information. We were able to monitor drug adherence, and for patients with low drug adherence, we installed on their phones pill adherence apps that reminded them on a regular basis to be taking their medications. For folks that tested positive for economic insecurity, our pharmacists had specific instructions about trying to switch them to generic medications or even combine medications that would have a lower copay. We had our health coaches work on lifestyle recommendations to improve the dietary sodium intake, as well as decreasing alcohol intake. And then we pushed all the reports of how folks are doing with these on a regular basis to both to the referring physician and to the patient directly through our patient portal and through Epic. This is an example of a report that's pushed out to the patient. It shows them how they're doing with their blood pressure progress, explains what their risk long-term for complications from their hypertension is, as well as what they're doing with their other factors, including dietary sodium intake and medication adherence. Once we had finished with the pilot, we realized this was such a success, we wanted to expand the digital hypertension program to all kinds of patients. And so we built a best practice alert in our EHR for poorly controlled hypertension patients to auto-select a referral to the digital hypertension program. We then expanded more staff, and we grew the pilot from original group of 156 patients to over 2,500 patients now in the digital hypertension program. In addition, we developed a way of trying to look at some of the social determinants that had a significant output and impact on the control of the patient's blood pressure in the digital hypertension program. This we called the health capability score. And basically it was a 4-point scale where folks received 1 point each for evidence of social isolation, for difficulties with health literacy, for low patient activation levels, and for financial insecurity as well. To try and assess the outcomes of the digital hypertension pilot group, we took that pilot group of 156 patients and matched on BMI, age, sex, and blood pressure to 400 control patients to try and establish a baseline to see if we could see any comparative differences with the effect of the digital hypertension program. We're very dedicated to this. We wanted to make sure this was not simply a tool, but we could actually change the outcomes in the control of hypertension. You can see from the paper that Dr. Milani published on this that our Table 1 showed no significant differences at all between the 400 control match patients and our 156 pilot patients in the digital hypertension program. And we looked at all kinds of things from baseline blood pressure to body mass index to renal function, percent obesity. All of them showed no difference between the control and the pilot group. In the pilot group, we saw some significant rates of different conditions that we know affect blood pressure control. Over 76% of our patients were physically inactive. Living in New Orleans, it's not surprising that 32% of our patients had a high dietary sodium intake. But we also saw a significant level of low patient activation and a significant level of poor technology skills. Interestingly, these patients were not on one blood pressure medicine on average. In fact, the average was 3.7 different blood pressure medicines. So these are patients that were having difficulty controlling their blood pressure to begin with, not patients with simply run-of-the-mill basic hypertension that was controlled on one medication. Well, here are the outcomes after 90 days of folks being enrolled in the program. And what you can see is a significant drop in green between base systolic blood pressure and final systolic blood pressure of over 10 points, of diastolic blood pressure of a drop of about 6 points, and an almost 10-point drop in pulse pressure drop without any significant change in our control group. A more effective way of looking at this is how many of the patients that we enrolled in our digital hypertension program achieved the goal of getting under 140/90 with their blood pressure, and how did that compare to the control group? So we know that when patients have an elevated blood pressure, the physicians are attuned to that and they're working to try and control that by adjusting medications. And in fact, 30% of our patients in the control group during that 90-day period were able to achieve blood pressure control through the interactions that they had with their regular physicians. But that's a stark comparison to the 71% that were able to achieve control with the digital hypertension program. That represents a 40% increase in the ability to achieve patients under control. And again, these were not simple patients, but patients that had multiple medications and were more difficult to control to begin with. Part of this was the medication adjustment, but part of it was other things that the health coaches were able to do. So we saw a drop in high baseline sodium dietary intake from 32% down to 7%, and we were able to engage patients more in their health care. So we saw a drop of low activation patients from 15% down to 6%. Sorry. We then looked at folks in the pilot group who were able to achieve control and tried to compare that to the 30% or so that were not able to be put in control during that 90-day period to try and identify risk factors which may contribute to those patients having more difficulty in being able to achieve control of their hypertension. And what we see is the following risk factors: being diabetic, being depressed, having low health capability scores, poor technology scores. All of these were risk factors that increased folks to have a higher likelihood of being more uncontrolled than in the control group. We also found that this health capability score, again, which was a combination of social isolation, health literacy, health activation, and financial insecurity, when you put those together, had a significant impact. So if you had none of those factors, you had an almost 80% chance of achieving blood pressure control within the 90-day period. Whereas if you had 2 or more of those factors, your chance of achieving control during the 90-day period fell down to 40%. So this really, again, speaks to the importance of trying to address some of these social determinants in folks' health care. Patients felt better engaged with this system. In fact, compared to the control group, they had a higher overall patient satisfaction scores by over 12%. They were more likely to take their medications, so both their calcium channel blockers and other hypertension medicines, and all hypertensive medicines together had an almost 14% increase compared to the control group of adherence to medication. Patients more involved in their health care with a significant drop, again, in the low patient activation patients. Patients felt better about their health, so they asked in surveys about what their overall health was doing, and in the pilot group, again, they felt their overall health was good. That number went from 19% up to 32%, a 71% increase. And if you ask folks about whether they were having difficulty with their mental health through PHQ questionnaires, again, the folks that felt good about their health and did not have any positive warning signs on the PHQ questionnaires went from 39% up to 69%, a 79% increase. When patients were asked to self-report how they were taking their medications, they went from 56% to 99% being adherent to their medications, a 76% increase. And it's also important for folks to have some discussion about why they're taking the medication, what side effects they have, et cetera. And so asked if they felt that they were able to discuss the medications with their providers. That number went from 31% up to 68%, a 118% increase in our pilot group. Let's talk a little bit about the financial implications from this. There was an article that was published from the group out of Columbia in the literature recently that estimated that if you look at patients who had uncontrolled hypertension and were able to bring those patients under control, that would result in a reduction of healthcare costs to take care of that patient of about $300 per patient per year. If we look at the 40% improvement in the pilot group compared to our control group and multiply that times the 2,500 patients we have now enrolled in our system times $300 per year, we are saving in healthcare costs on the group of patients that we have already enrolled in our digital hypertension project of over $300,000 per year. If you look at the number of hypertensive patients we have in our accountable care organization or our Medicare patients who are in our MSSP program, which we are now in a Track 2 program, so we are at downside risk for, that translates to almost $5 million potential savings in cost of care delivery to those patients if we were able to enroll all of those patients in digital hypertension programs. And if you expand that to all of our patients, not just those ones we're at at-risk contract to, that number jumps to over $14 million per year. Let's switch gears now and talk about our Connected Mom program. MOM stands for Maternity Online Monitoring Program, in addition to MOM. And we're very excited about putting this program out for our pregnant patients. We're going to talk a little bit about the eligibility, the data capture, device integration and design, as well as the operational deployment, and then finally some of the outcomes from this. So pregnant patients were enrolled by their obstetricians in our Connected Mom program. We accepted only low-risk pregnancy patients, so we excluded patients with diabetes or a history of preeclampsia or other major medical conditions which made their pregnancy more high risk. We also excluded twins and mothers of low maternal age below 18 or high maternal age as well. Mothers had to have a smartphone. They were given a free kit from our OBAR with a digital wireless blood pressure unit, a digital Bluetooth scale, as well as urine strips to check for urine protein, which they submitted those results through the patient portal. So patients had to be active again on our MyChart patient portal so we could reach out to them. This is the kit that they were given. It here has the digital Bluetooth scale as well as a digital Bluetooth blood pressure machine, and then the urine strips, which they submitted the results of through MyChart. We set this up again at the O-bar. These devices, both the blood pressure monitor and the scale, are submitted their data through an app to Apple Health Kit, which then integrated back into Epic. We asked for 1 blood pressure reading and 1 weight per week. And the urine protein strips were submitted at 3 times at designated times during the pregnancy. The main purpose of this was to see if we could reduce the number of visits that a patient needed to have while increasing the number of weight and blood pressure readings that we attained on these patients. So both high convenience, better quality monitoring, as well as improved satisfaction. As these patients were also part of a capitated global fee for their obstetrical care, having the obstetricians have an increased number of slots where they can see patients, increase the number of patients that they could take care of and provide obstetrical care for, which would have financial benefits to our organization. We also wanted to create a frictionless method for pregnant women to be able to choose a pediatrician and book an appointment for their newly delivered baby within a few days after delivery. So this is the paper algorithm that patients were given. You can see weekly recordings of their weights and with their blood pressures, and they're all being submitted and monitored into the system, as well as their routine office visits now, which decreased by about 25 to 30%. And the 3 readings for the urine protein tests at the various times in their pregnancy. They were also given reminders during this time to come in to make sure that they had their prenatal testing done, as well as their prenatal glucose testing to rule out gestational diabetes. What we saw was, if you look at the standard care for prenatal visits, assuming the care begins at around 12 weeks post-conception, we typically see 12 to 14 visits before delivery. In our connected mom patients, we cut that down to 8 to 9 visits. So about, again, a 25 to 30% reduction in the number of obstetrical visits. This is our Ochsner Baptist Hospital, one of our major obstetrician centers with over 10,000 deliveries a year. And this is what the O-bar looks like. You can see here our technical support staff and the patients coming in, giving them their phones and having the apps installed on their phones and showing them exactly how to work it. We recorded video introductions for all of our pediatricians. They had about a 5-minute period where they could speak about what their philosophy was of caring for babies, as well as their personal background. And then we allowed that information to be portaled through the patient's portal to all of our pregnant patients in Connected Mom programs, so that they can choose a pediatrician and see a little bit about them by seeing these videos on their pediatricians that were available to take care of their newborn babies. Switching gears again now to our diabetes program, you can see from this graph why diabetes might have been an interest for folks in Louisiana. Again, the Gulf South represents the heart of the increased incidence of diabetes in the United States. Our digital diabetes program was really all about providing a team-based approach to caring for patients with diabetes. This involved diabetes educators, as well as pharmacists and health coaches. We looked at the eligibility. We'll talk a little bit about the eligibility, how we captured the data, how we integrated the devices, what our guideline-based care was, how we again began to operationally deploy this, and what are the outcomes that we started to see with this program. First of all, the digital diabetes program to date is only dealing with type 2 diabetes. So type 1 patients are currently excluded. We have plans in the future to try and expand that to other diabetic patients. Folks had to have a smartphone and be able to purchase both a Bluetooth-enabled digital wireless glucometer as well as a Bluetooth-enabled digital blood pressure machine, and again had to be active on the patient portal. We created a digital diabetes medicine registry in our Healthy Planet system of Epic so we could track these patients, as well as develop questionnaires. And again, the readings from the glucometers and the blood pressure machines were sent to Epic directly via Apple Health Kit. So this is what the digital Bluetooth-enabled glucometer looks like with the strips. It's produced by iHealth Systems. So the strategy, again, was developing a PharmD approach who was trained in diabetes management following the 2017 ADA guidelines. I'm a health coach to help with the interviewing and doing lifestyle changes as well as diabetes education. We wanted to monitor all the blood glucoses electronically, and our main goal was to try and achieve tight control of their sugars while eliminating those dangerous hypoglycemic events. And as a secondary goal, we also wanted to complete any outstanding care gaps in the health maintenance, such as diabetic eye exams and urine screens for microalbumin. These are some of the questionnaires and other information that we gathered on our digital diabetes program patients. So we looked at what their diet was, how they were adhering to medication, what their living circumstances were, financial concerns, their social network and isolation areas, again, stop-bang questionnaires for sleep apnea, screenings for depression, patient engagement, physical activity, health literacy, transportation issues, access to care, and a new criteria for diabetes distress. We looked at how distressful hypoglycemic events and other complications from diabetes were for those patients. All this data was calculated and put into our system, and we developed metrics for real-time analysis of this to risk stratify group patients into low, high, or medium risk groups to try and address which patients needed the most attention for the care of their diabetes. We also created custom education videos on these topics here, and are able to port those videos out to the patient portal for the patients to see so that they can, again, learn a little bit more about their diabetes and how to care for it. This is the monthly report we push out both, again, to the patients as well as to their providers, showing them, again, what is their average blood sugar, and most importantly, how many highs they're having, how many normal blood sugar readings are in the normal range, and most importantly, how many low blood sugar readings they're having. We also identified any care gaps they had in their health maintenance, such as when the last A1C was, when their last I1 exam was, and when their last urine microalbumin was. We gave them advice about diet and exercise as well, and again, these are personalized and sent out to the patients each month. What are the results? So what we saw was a significant decrease in A1C readings in these patient populations. So we're able to drop their A1C from 7.5%, which we would say is average control, down to 6.8%, which is tighter control, without any increase in hypoglycemic events. The financial impact of that is significant. The data on how much money is saved for improved glycemic control is kind of all over the place, but data from the YMCA would estimate that a 0.7% drop in A1C will result in about $1,000 per year per patient saved. Data from the Geisinger studies looked at over $5,000, so something in that range is a value that we can use to try and quantify the financial impact from this improved glycemic control. Patients were more likely to get their A1Cs tested, from 84% up to 97%, were much more likely to have their eye exams performed, an over 20% increase in that, as well as a 20% increase in nephropathy screening using urine microalbumin. We had some issues that we were able to overcome about getting strips for patients. We needed the strips that were going to work with our glucometer machine, and so we talked to our insurance companies that cover these patients to convince them that even if that test strip was not on their formulary, to go ahead and cover that test strip so that they can use the appropriate test strips with the Bluetooth-enabled glucometer. And we also made it more convenient for the patients because we were tracking how many readings we were getting, and we know how many strips are in a bottle. We were able to auto-reorder strips for patients based on their usage that they were reporting back into the system. Overall, if you look at all three of our digital medicine programs, the hypertension, the connected mom, and the digital diabetes medicine program, we really see some outstanding numbers. The number of clinical touches, or the number of times that someone who's a healthcare provider is able to reach out to the patient, whether that was a healthcare coach, a PharmD, or their physician, compared to our standard group, increased by over 900%. Our patient satisfaction scores went up 70%. We're almost twice as likely to get patients to goal through these programs. We had an increase in 14% in their adherence to medications and a 22% increase in our ability to close care gaps in their health maintenance. All this at the same time, we're actually decreasing the number of office visits for these patients. So we saw, despite all those improvements, a 29% drop in the number of office visits, again, freeing up capacity. As we know, with less and less availability of physicians to take care of patients, capacity to provide care is a crucial issue that we see for the future. So in summary, we've really increased the contact and outcomes with our patients without increasing the number of office visits. We've proven that guideline-based care can improve outcomes. And most importantly, we've proved that this device technology is ready to go. It's able to be fully integrated into our EHR. This is not some distant future state that we are off in the future to wait for. We're able to do this right now. We also see that it takes a team approach to do this type of care, and we've become very convinced with the data that we've seen from the digital program that lifestyle and social determinants represent a key component to care. And as you'll see in some of our discussions on our Davies talk about our population health, we are committed to using social determinants as a factor in driving how we're caring for patients in the future. So I'd like to thank the Davies organization again for the opportunity to present this data in the webinar. It's been our pleasure, and we look forward to hearing from you. If you would like to begin the road down digital medicine, to please contact us. And again, thank you all for your time and attention.
Thank you, Dr. Burstein, for another great presentation. And I also want to remind folks where to go find other great presentations like this one, and that can be found on the Davies website at hims.org/Davies. You can find these presentations and information on how to apply for Davies at the same location. And once again, thank you so much for these great presentations.